podcast. Conversation with Dr. Sushrut Babhulkar. This week's guest Dr. Nick Kanakaris, Clinical Director, Leeds Major Trauma Center, Hunt Senior Lecturer, University of Leeds, Leeds Teaching Hospitals NHS Trust.
Hello friends, we are on to our next podcast, and this time we have my great friend from Leeds coming over to us and talking to us on peri-implant and peri-prosthetic fractures. My friend named Nick Kanakaris, who is leading the Leeds Trauma Unit, University of Leeds. He originally comes from University of Athens, and he has a great experience in pelvis and acetabulum fractures. And today he holds the trauma center of Leeds. So Nick, welcome to the podcast.
Thank you very much. Hello everyone. Thank you, Prof. Babhulkar, for the invitation. I'm very, very honored and happy to be with you.
Thank you, Nick. So today's topic, friends, is peri-implant and peri-prosthetic fractures, which is on a great rise, mainly because of growing number of procedures, orthopedic procedures, joint replacements, trauma surgeries, and our patients demanding continuously more and more, life expectancy becoming better and better with healthcare improvements. And of course, there are certain issues which have increased the number, like for example, maybe some occult fractures which are a result of intraoperative trauma. Of course, there are some disproportionate impact on women and elderly population, resulting into peri-implant and peri-prosthetic fractures. But of course, low energy trauma, some amount of significant comorbidity, osteoporosis and osteopenia, rheumatoid arthritis, and revision surgeries all contribute to the increased incidence of these fractures. And there are various classifications from Vancouver classifications, ABC classification, XYZ classification, and we are all confused as to choose what's the best classification. Just to reiterate about Vancouver classification, it's divided into A, B, and C, wherein A fracture for proximal femur is at greater trochanter or lesser trochanter, AG and AL. B is divided into B1, B2 and B3, wherein B1 is around or just below the stem, wherein stem is well fixed. B2 is just below the stem, wherein the stem becomes loose. B3 is at or just below stem with a poor bone stock, and C is well below the stem. So Nick, my first question to you is, there are so many classifications. What you think is the best classification to be used?
Well, that's an important question. It's not just a technical, I think, issue, which classification we use, because it represents how we understand the problem we face, and hopefully it leads us also to decision making and planning.
Correct.
If you think of it, from 1964 that the first one was published, the classification of peri-prosthetic fracture of Paris Jones, we have about 30 more classifications. This is an indication that nothing is optimal, and everyone obviously has a new idea of how to solve the problem. I think the most comprehensive for an audit of our operations or of our center's activity, the most comprehensive would be the Unified Classification System of 2014. That takes into account exactly the principles of the Vancouver classification that you very nicely obviously summarized, but also adds different components as far as the location of the specification of the particular fractures. However, even that one, I think it is missing central points which are helping us decide and plan. And this is, for example, none of the classification, they mostly focus on location, on stem stability, and then on bone stock. None of the classification speaks about the presence or not of infection. We have some of the fractures, likely the minority, that may be relevant to loosening, and this could be septic or non-septic. So you need maybe to adjust your planning. Or they don't speak about specific nature of the fracture. If it's a short oblique or a transverse at the tip of the stem, it definitely behaves differently than a spiral or comminuted fracture, which is a bit more friendly on the healing process. Or they don't speak about the nature of the stem. Is it a cemented or an uncemented? Is it a cemented of a certain design, tapered stem, or is it a composite beam or collar-based stabilizing cemented stem? So these are parameters. And they miss the most important parameter, which is the host. The host, the patient, the state of the patient, the functionality of the patient before the accident, as well as, the nature of comorbidities, the patient's compliance. They are also factors that, irrespective of what is the subtype of the fracture into the Vancouver, it may lead you to a different decision making. So I think we don't have the optimal, but I think the UCS is the most comprehensive. But we need to think a bit beyond classifications very often.
Great, Nick. That was very helpful. And for audience benefit, what Nick was talking about was Duncan et al.'s classification. Duncan and Haddad described this classification in 2014 and published it in British JBJS. And today, this classification, which is called as New Unified Classification System or UCS, covers management of all prosthetic fractures. It actually expands the Vancouver classification and includes 3 specific fracture types, D, E, and F, and combines that with AO-OTA fracture classification. So it can be extrapolated to even peri-implant fracture. So that's probably the most helpful. I completely agree with you, Nick. My next question to you is, Nick, what according to you are the factors which affect the treatment and how we should approach this patient who comes to us with a peri-prosthetic or a peri-implant fracture?
Yeah, thank you. I think this is obviously a most crucial question and answer for the clinician and the patient. So I think it starts by assessing personally the patient. And it's not just an X-ray, what I want to say. So you need to go and see the patient, because for me, the patient factors are probably the most important. As I said, compliance, comorbidities, risk factors for a big surgery. And then, of course, the fracture, the pattern of the fracture, of course, the parameters as far as the location, the type of the fracture, the stem stability, if this is can be assessed pre-op, is a big question and affects decision making. The quality of the bone stock around it. And of course, I would add, one of the important factors is the expertise which is available. Meaning, these type of fractures are not necessarily fractures that sit with a trauma-only surgeon or with an arthroplasty-only surgeon. They sit in between both groups of clinicians, and they need both skill sets. So unless you possess both skill sets, you need to make sure that your hospital at least has the expertise, or else better refer the patient for the at least complex ones.
Nick, I'm going to add to this the importance of pharmacological treatment, because severe osteoporosis affects majority of these patients who come to us. And of course, age and comorbidities and prolonged immobilization will add to longer healing time, more non-union and complications rates. And of course, I want to, at this point in time, take the name of my friend and your senior colleague, Peter Genidis, who, he taught us the diamond concept of fracture healing, which should be taken into consideration in peri-prosthetic, peri-implant fractures as well. For the benefit of audience, again, according to this theory of diamond concept, the osteogenesis process in bone union can be supported by the implantation of mesenchymal stem cells, scaffolding, and growth factors in the fracture bed. Additionally, of course, surgical procedures would provide appropriate mechanical and biological environment, the so-called biological chamber, in order to efficiently enhance the physiological healing process. And of course, this diamond concept now, Nick, has evolved into pentagon concept, wherein it also includes adjuvant multiple systemic pharmacological treatment as a key role therapy to enhance bone metabolism. So with this background of also considering pharmacotherapy, let's go to our mainstay, which is the surgical fixation. And Nick, I want to ask, what's the significance of type of stem when we always debate about B1 and B2 fractures, and we talk about this? What's your thought process on this?
Yeah, basically, I think it would be, I don't know, a bit of not a kind of solid answer if somebody would expect that all stems and all fractures are the same just because they are located around the bed of the stem. The stem design, and either if it's cemented or not, does play a role. First of all, it's proven that it plays a role into the production, into how the fracture is created. We know that, for example, tapered stems, they have a fracture pattern on periprosthetic, in the periprosthetic category, that is not relevant usually to loosening. It is relevant to the low energy mechanism of a simple fall. And the stem acts like basically as an axe, splitting due to its design the shaft. And because of the cement mantle, if that is solid around the stem, basically produce a lot of these spiral fractures we see, maybe with a butterfly, or those that we call nowadays reverse clamshells as fractures, which is in 2020, I hope most of us read a nice publication speaking about how to understand how the stem produces and behaves around the periprosthetic fracture of Karam et al. It's an Australian group. In 2020, they published it on the Journal of Orthopedic Surgery and Research. And they describe 4 categories of these B-type fractures, and which ones we can consider amenable to fixation, even if the fracture pattern and the extent of the fracture indicates instability of the stem. And we do need this solution and understanding because we have frail patients that cannot always undertake a proximal femoral replacement or a revision, big type of stuff, high bleeding and high, insult to the physiology of the patient, revision surgeries. So we need something to temporize, fix and heal. And there are nowadays a lot of studies that speak about this new concept of depending on how the fracture looks and what type of stem you have, some of these fractures, the B2s, as far as the X-ray, can be even fixed. And we have a bit experience on that as well recently. We are about to publish a series of hours of 50 patients on that type of problem.
All right. Okay, so anything new on confirming implant stability? How do you go about that?
Yeah, basically, we all use obviously the X-rays. We see the extent of the fracture. Some fractures are obviously that it's quite obvious that the fracture is with an unstable, obviously, stem. But there are the ones which are in between. Mm-hmm. So those in between, we do CT scans now. There is new technology on the scanners that you can actually use clever software and make sure that you don't have a lot of artifacts. So you can see the extent of the fracture from a CT scan. Very commonly we do a CT scan if we are in doubt. When we end up always screening them in theaters, either under fluoroscopy or via, depending on the fracture location, via fracturoscopy. So through the fracture, you can try to press the stem, but all of them are inconclusive because the most reliant would be, and relevant would be, if you actually produce an arthrotomy and you kind of stress the stem via the proximal exposure of the stem. But of course, when you want to fix, this is not your approach. This is an approach if you want to revise. Yes. So most of us use the CT scan and screening. And as I said, because we nowadays can fix effectively even those that are in between, especially for frail patients, I am not that concerned that we don't have a very conclusive differentiator between B1s and B2s. The most conclusive is the patient's state If the patient can tolerate a revision, if you are in doubt, revise. If the patient cannot tolerate revision, then even if it's an unstable one, probably fix to allow the patient to survive, and then secondarily, if you have secondary substance, you can proceed into a secondary revision.
All right. Okay. Nick, give us something on the supracondylar femur fractures. Anything new happening in the world about them?
Well, their classification obviously is again deficient. Probably the one I use is the Su and Kubiak classification of 2007 JOT that speaks about the possibility and the extent of the fracture if it allows you to use a plate or a nail into the fixation, obviously, pattern. But this is also missing another parameter, as all classifications around the total knees, which is one. The following: the fact that another factor is the stability of the joint, not of the cup, not of the shield of the total knee, but of the joint itself as a result of the fracture. Many of the fractures we see, they have obviously involvement of the medial condyle or the lateral condyle, so where our ligaments originate from. And they produce instability subsequent to the fracture, which will compromise the outcome of the fixation, as well as potentially make a revision, definitely a constraint, obviously a revision and more complex surgery. So I would say that is one thing, the understanding of the knee stability as a factor. The second thing that I think has come across lately is combined solutions like dual plating for some of these fractures, or combining nails and plates into the basically targeting earlier mobilization and faster recovery of our frail patients. So I think these 2-3 items are what is evolving into the supracondylar, let's say, around the total knee arthroplasty problems.
Anything new happening on the revision total hip arthroplasty front?
Yeah, basically a lot of new things, meaning this is evolving parallel to anyhow the revision arthroplasty techniques in general. I mean, we are using now much more sophisticated maybe or clever implants, coated, partially coated, modular. I think that's a big evolution that allows us to address these fractures and as well as stabilize the hip and reconstruct the joint much more effectively. And a concern is dislocation in some of these fractures that we reconstruct following and we revise following an arthroplasty, following a fracture with a revision arthroplasty. So we use nowadays either we consider a large femoral head or a dual mobility cap or a fully constrained acetabular component. Of course, the ETO, extended trochanteric osteotomy, is a workhorse. It is effective to allow your revision to be sufficient. We use all these, as I said, modular total revision hips, which have a tapered ischemic fitting stem with a modular body and neck and the head. We do rely on at least 4 to 6 centimeters across the fracture and across the isthmus bypass. So that makes it stable enough. If we don't have enough distance or the isthmus is compromised, then we need distal anchorage with screws. And of course, there is the solution for the frail patients that you revise to do a cemented revision rather than these uncemented modular stems, which offers maybe earlier mobilization, but I should be preserved probably nowadays for the very frail and poor kind of biology patients.
All right. So, Nicholas, that brings us to the last question of today's podcast. I want you to take a glimpse quickly on non-arthroplasty related peri-implant fractures. So, what's new on those peri-implant fractures wherein we have put in a plate or a rod? Are they same as peri-prosthetic fractures?
They are the poor relatives because they are an under-reported and under-recognized entity. They are big in numbers because we implant devices anyhow, not only arthroplasties, but also fixation devices. I think they are a bit different because there is a parameter here. First of all, classification, non really existing, at least a comprehensive one. Here the issues are the following in my understanding and according to the recent publications of the last couple of years. The type of implant, is it a nail or a plate pre-existing the fracture? The location of the fracture in correlation to the implant, is it distal? Is it proximal to it? Is it through it? So it's also a fatigue failure of the implant, of the pre-existing implant. The number of implants, then we might have implants proximally distally and this fracture is in the in-between zone of stress risers. As well as is the extremity aligned? And the most important, is the previous indication, the fracture, pre-existing fracture, healed or not? And if it's healed, is healed in an acceptable fashion, or is it a malunion that you may take the opportunity and correct everything with a new fracture, I mean. And of course, the big unknown always and the fear of everyone is infection. Infection is a parameter in all these revision and secondary problems and complications, because until exclusion, it's always suspicious. And every patient should be worked up and our planning adjusted and have alternatives accordingly to the presence of infection.
Yeah. And I think the passing remark that you made, Nick, was very, very significant. To use double plate at variable levels to avoid that stress riser, or use a nail plate combination for some of those difficult fractures wherein you would add mechanical stability intramedullary as well as extramedullary at some situations in some region. So thank you very much, Nick. So in summary, ladies and gentlemen, the combination of mechanical stability, of course, obtained by modern surgical techniques, associated, of course, with pharmacological systemic treatment, seems to be the way to go in the future. Thank you very much, Nicholas, to join me in this very interesting podcast. And
it has been my great pleasure.
Soon. Thank you. Bye-bye. Take care.
Take care.
POO Podcast.